our next topic that we're going to talk about is, largely considered by many students as, being one of the most exciting stories that we have a chance to discuss. And that's the story of HIV. Okay, I told you I'm going to tell you a fairy tale about AIDS. So first, the form on the molecular story. HIV belongs to the genus lentivirus of the family Retroviridae. And I'm not so concerned about lenti, but I'm really concerned about retro. And later you will see why we call this virus a retrovirus. So it has an RNA genome, single-stranded, which is encapsulated, and the capsid is enveloped. It's medium-sized, 80 to 100 nanometers in diameter, usually spherical. And in the envelope here, you can see the molecules of glycoprotein called GP120. GP, not surprisingly, stands for glycoprotein. This viral glycoprotein binds to its cellular receptor. And name of one of the receptors you will recognize right away. It's the CD4 molecule, which can be found on which cells? CD4 cells. So those are the primary cell type that virus infects, CD4 cells. Virus also has a couple of so-called co-receptors, CCR5 and CXCR4. I'm not going to ask, which of the following word soup is the co-receptor for HIV. That makes sense? Like, I'm not going to ask you CCR5, CCR3, CCR4, or CCR7. But the point is, CD4 is the main receptor, like a main key to the house. And CCR5 and CXCR4 are additional keys. That essentially defines the tropism of the virus, the cells that it infects. Primary cell type is CD4 T cells. The virus can also infect macrophages. But generally, when we consider clinical HIV infection, we think about CD4. Now, first interesting tidbit about HIV infection. Some people have defective CCR5 gene, so-called delta 32 mutation. These people are resistant to type 1 HIV virus. It was discovered in 1988, if my memory serves me well, when one gentleman who lived in New York came to, I believe it was Columbia University, but I wouldn't take my words to the bank in terms of which university it was. And he said that he's gay and a lot of his friends, it's late 80s, a lot of his friends and partners died of HIV. And he never had disease. And it was bizarre to him because at this point people knew that it was sexually transmitted. Make sense? So, well, it didn't make sense for him. And researchers started to analyze his CD4 cells and found that this co-receptor, and it's important, co-receptor, meaning that it is also required, right? Co-receptor is as a defect in the gene, meaning that it doesn't work, meaning virus simply cannot enter his CD4 cells. Does that make sense to you? And the first response was, yay. And then, so what? So yeah, this person has a defect in the receptor, but it's not a way to treat. You see what I'm trying to say? If you do have this deficiency, you're resistant against HIV. That's great. Good for you. But we can't make it, abundant thing in a person, like as a treatment. In fact, that feature was used, I wouldn't call it a treatment. It was used a couple of times. Now, I think there are two cases like this. First was in Germany when a person with HIV developed leukemia. And the treatment was a bone marrow transplant. So that person received a bone marrow transplant from a donor with that mutation. So when new CD4 cells got produced, they were refractory to his HIV, and residual virus that was kind of floating around in the blood got cleared eventually. It has nothing to infect, so person was, technically speaking, cured from HIV. But curing from HIV using bone marrow transplant from a person with a specific mutation, it's a bit of an overstretch, as you can imagine. Now, how prevalent this mutation is, it's really low prevalence, found mainly in the people of North European descent, talking Scandinavian, Northern Germany, Baltic states, about 1% of those folks. Practically absent in Southern Europe, Africa, African Americans, Pacific Islanders, Asians, non-existent. Okay, so for some reason, for some bizarre reason, that mutation is found in that ethnic group. Now, the replication cycle of the virus is super interesting. And we're going to start right here. So this is HIV particle, which interacts with its receptor and then co-receptor. And it adheres to a CD4 cell surface. Then, you can imagine that for the virus, main purpose is to deliver its genome into the cell, because that's where all the information is necessary for replication. So for HIV, now it is established there are two ways for the virus to enter the cell. It can either fuse. So the envelope of the virus, you see the envelope here? It fuses with a cell membrane, and the capsid that contains viral RNA is released into the cytoplasm. Does that make sense so far? Now, second way is endocytosis. So either fuse or endocytose, one or another. Actually, the evidence for endocytosis of HIV was shown practically like several years ago. Before that, everybody thought it was fusion. So what happens next? So capsid is in the cytoplasm. Capsid gets disassembled, okay, releasing RNA, viral RNA, into the cytoplasm of the CD4 cell. Now, interesting thing, if it happens too early, cell can detect viral RNA, which is pathogen-associated molecular pattern. It can detect viral RNA in the cytoplasm, initiate antiviral state, which leads to so-called abortive infection, meaning that virus basically is cleared from the cell. Does that make sense? So cell notices it. The surveillance molecular mechanisms notice the infection and clear it out. Does that make sense? Well, if it doesn't happen, then the most bizarre step occurs. Remember we talked about gene expression, how DNA is transcribed into RNA, and RNA is translated into protein. Remember that story that kind of went through the entire course. It turns out that viral RNA is reversely transcribed into a DNA. So, remind me please, molecule of DNA, how many strands are there? Normally in a cell. 2, so double-stranded, right? And RNA, the mRNA is 1 strand, so single-stranded. So that's normal transcription, right? Double-stranded DNA into single-stranded RNA. So HIV does exactly opposite. It uses its single-stranded RNA genome as the matrix for synthesis of the double-stranded DNA copy. Double-stranded DNA copy of its own genome. Does that make sense to you? Yeah, that's what happens. It was discovered by the process of reverse transcription. It's called reverse transcription. So enzyme that facilitates it is reverse transcriptase, and that's reverse transcription. So enzyme that facilitates it is called reverse transcriptase. This was discovered by, I believe, David Baltimore in 1976. Okay, Baltimore and Terman, I think. Yeah, they got Nobel Prize for it, no doubt. So RNA is transcribed into double-stranded DNA. And this double-stranded DNA immediately enters nucleus. And then the second bizarre step occurs. Its double-stranded copy, double-stranded DNA copy of the viral RNA genome gets integrated into a cellular chromosome. So enzyme called integrase incorporates that double-stranded DNA copy, also called a provirus, into the cellular chromosome. Does that make sense? You see what I'm trying to say? And it stays there forever. This is why people, they are HIV positive. HIV positive for life. Because the virus, the DS double-stranded DNA copy, is in their DNA. That's it. It's not going anywhere. Make sense? So the virus can stay latent, being incorporated into cellular DNA for years. Having a 5-year latent HIV infection is pretty normal. Okay? And latent, I mean, there's no replication, there's no symptoms, people's fine. We still don't really know what triggers the reactivation of the virus from latency. So this graph on the left bottom, shows you the dynamic of the virus particles, shown here in the red, okay, and calibrated on the right side, versus the CD4 cell count. So normal count is about 1,000 per microliter. And immediately upon the infection, you see there's a spike in the virus particles. There's obviously a decrease in CD4 cell counts, because this infection on the right, it actually kills CD4 cells. Does that make sense? And then, after that primary acute infection starts to decline, CD4 T cells, the numbers start to kind of go up, recapitulate. Okay? And that curve here is actually too steep. It actually is much less steep, much more horizontal, let's put it this way. Okay? So after that acute infection, virus enters latency and nothing really happens. If you want to see what latency looks like, watch the videos of the band called Queen, starting from 1986 all the way to 1989 or 1990. Okay, you will see that in 1986, Freddy is already infected, but you're not going to see anything. And you go from kind of magic through miracle, nothing happens. Or, what's that next one? Kind of magic, then for the Highlander movie, I forgot the name of that. Who Wants to Live Forever, Miracle, and then on Innuendo, he's actually sick on the last album. And you look at him during those videos and he looks absolutely terrible. So that's actual final stage of HIV and AIDS at this point. All the way before, he looks fine. No signs, no symptoms. So eventually the virus reactivates, and the number of virus particles starts to grow exponentially. The number of CD4 cells decline, and you can imagine no CD4s, cytotoxic lymphocytes aren't activated, macrophages are dysfunctional, B cells are dysfunctional, your immune system is in the trash, so a bunch of opportunistic infections. Does that make sense? Now, what happens when the virus is reactivated? Well, basically, I'm sorry, classic gene expression. So this provirus here gets transcribed, okay, into RNA. Some RNA fragments get spliced. Spliced mRNA leads to protein synthesis. Unspliced copies will be packaged here in the capsid and then enveloped. That makes sense? And then the virus will bud through the membrane, like I think I made this comparison, like in the advertisement for chocolate-covered strawberries. Strawberries bud through the layer of the chocolate. Okay, so this virus gets through the membrane. Really important step, as we will see, is that the virus that leaves the cell immediately isn't mature. It already has left the cell, and then viral protease finally makes the virions mature. We're clear. So you've got attachment, entry. This step, when RNA is released, is called uncoding. Then you have reverse transcription, integration, transcription, translation, assembly, and release. So this was really unusual when reverse transcriptase activity was discovered. Now let's talk a little bit about the disease itself. So this image shows you the prevalence of the virus in different parts of the world. So global prevalence is 0.8%. You can calculate the number of infected people. We have 7 billion, right? 8, let's do 8, I don't really care. 8 billion, so 1% is 80 million. 0.8%, 64 million people in the world are infected with HIV. Okay, so is that pandemic? Sure. But we can't expect it. Now, you see that the highest prevalence is in Africa due to multiple reasons. Some of them are, majority of them are economic reasons. HIV is the disease of poverty. People are not aware, poor education does not allow them to take, they just don't know about precautionary measures. Some of it minimal, but there's some influence of weird local customs, like sex with a virgin cures HIV. Obviously it doesn't. I'm really interested why Middle East and North Africa have such a low prevalence. I have my own cultural speculation about it. Those are heavily Muslim countries, and they have very restrictive laws on sexual relationships, so that might contribute. And as far as I know, drugs are not really welcome there, injectable drugs, so that may contribute to the limited spread as well. Now, what US has, what, pretty low, okay? Russia's pretty high. Russia, Eastern Europe. I can tell you that there are, I just kind of know the situation, there are some spots back home which have astronomical rates of HIV, mainly economical, also human stupidity reasons. We'll talk about those. But you see that Africa is the most prevalent. Now, transmission. That's an exhaustive list. So, Blood, meaning transfusion, really. Can you get HIV via blood transfusion in the United States? No. Every batch is tested. Semen, seminal fluid, vaginal fluids, rectal secretions. Meaning, you can get HIV through vaginal sex or anal sex. Okay? And it's kind of interesting because it turns out that not only genital mucosa is suitable for HIV transmission, meaning that, if infected men and uninfected women have sex or other way around, it can be transmitted both ways. But it's also interesting that virus can be transmitted through rectal mucosa in anal sex. That makes sense. Now, the main cause of transmission in the US, unprotected anal sex. Okay. Heterosexual contacts in the United States, secondary. Intravenous drugs. There were studies showing that even, people that financially limited and have to share needles to use injectable drugs, sometimes rinse the needles. Virus can be transmitted if the water is not changed for instance. Now, this route of transmission plays minor role in the US because of the programs for distributing free needles. These programs work. It was very convincingly, unfortunately, shown back home when some moron decided that if you basically stop giving needles to drug users, they will stop using drugs. That was absolutely dumbfounded idea. They did not stop using drugs, but the rates of HIV and hepatitis C skyrocketed by about 70% in 1 year. So basically, one person with one signature caused an epidemic of HIV and HCV. Now, I'm going to talk about, accidental needle stick, obviously, healthcare workers are at the risk. Vertical transmission. I'm talking US. Okay, I'm talking US. I'm not talking Africa, for instance. In US, vertical transmission, super rare. Pregnant women and breastfeeding women can get HIV therapy. It basically protects the baby. It's safe enough to give pregnant women. Baby does not get a virus. I think last or 2 years ago, the number of HIV rates were like 26 or 28. Vertical transmission of HIV was like 26, 28. The entire country. So imagine, that's super low. That's like super low. Extremely rare. Blood transfusion, I put it in extremely rare, but really no. Via broken skin, yes. Blood exposure. Bite. Again, blood exposure. Can it be transmitted via oral sex? The answer is, it's complicated. Here's the deal. It cannot be transmitted from mouth to vagina or mouth to the penis. It can be transmitted the other way only if there are blood exposure in the mouth, like gingivitis, any kind of bleeding. Does that make sense? Deep kissing, actually in the manuscript that I read, it called something like traumatic kissing or something like violent kissing. They had a different term. So basically people are biting each other in the mouth. That's kind of an interesting practice. So, but what I'm trying to say, either sexual transmission or blood transmission. In Africa, the main routes are sexual transmission and vertical. Vertical is one of the most important and most preventable, honestly, but the price, and we'll talk about the price. Now, the transmission, where it is most common in the US. In the north, it's in the urban areas. Okay? You can see the distribution. So these are two really wonderful pieces of data. So this piece shows you the number of HIV diagnoses in 2015 per 100,000 patients. So you can see that the South is heavily affected, okay, and poverty. Seriously, it's a disease of poverty. Now, in New England, we talk Massachusetts, Washington, Maryland. I mean, I think they merged Washington, D.C. and Maryland. Oh, no. D.C. is pretty high. I can see the number. It's like 66. It's really high. In D.C., the rate of transmission is really high. I don't know why Nevada stands out. Yeah, I think so. It's probably Vegas. So, and then you look at Midwest, you know, it's pretty low. And then interesting data, it's the risk to acquire HIV during lifetime. Okay? 1 in so many. So I believe the highest is something like DC, 1 in 96. Okay? We can try, or Maryland, you know, it's pretty high. And the lowest, not surprisingly, I just know that that data is North Dakota, but let's admit your chances to meet a living person in North Dakota are pretty low in general. Now, if you would look socioeconomic distribution, so I picked some of the graphs. So that shows you, that graph on the left shows you the distribution of HIV positive people in the households with different incomes. And you can clearly see that the lower the income, the higher the HIV rate. You have to be careful drawing conclusions in terms of the association versus, you know, causation stuff. There's definitely a good correlation. It's probably, you know, lack of education, maybe HIV takes an economic toll, so people don't earn that much and stuff like that. Now that shows you the distribution in the poverty areas versus US overall. So you can see that this is disease that affects mainly African Americans. But if you look specifically at the areas with the same level of income, it's fairly evenly distributed. And the rate of HIV positive people in the poorest population in the US is, as far as I remember, between Gambia and Angola. I'm not trying to say anything bad about those countries, but they have real, like, serious problems, and the economy isn't as developed as the United States. So I think it's kind of a shame that it's at the level of Gambia and Angola. Now, if we try to break down the population story a little bit more, so this data here show you more detail. So term MSM belongs to HIV epidemiological research. MSM means men having sex with men. So you see, that's the dominant population. That's at the highest risk now. And then we have African American men and women, and then Hispanic heterosexual women and white heterosexual women. Okay, so you can see that there are two main associations: poverty and race. Again, I use word association. It's a complex relationship. It's not just, you know, you poor, you're going to get HIV, or you black, you're going to get HIV. It's more complex. Now, this is a terrible, absolutely terrible table. Okay? Let me explain. I should use it as an example how badly the table can look in the $200 book. I stole it from $200 textbook that we used to recommend for this class. It has, like, not just typos, like misplacements of text. The reason why I stole this is because I'm lazy. I tried to come up with a table myself, and I realized that I need to use the font with a size like 6 to fit all the secondary infections in the way I want it, or I need like a wall poster, gigantic wall poster. So every system can be affected. Some of the most common, and I will highlight the most common characteristic ones. So let's start with the skin. On the skin, by far, sarcoma Kaposi. Remember we talked about that herpes virus? Kaposi sarcoma herpes virus? That's it. Purple blotches on the skin. Herpes, CMV, like eye infections, that can happen. Nervous system. Characteristic, cryptococcal infection. It's the infection with the fungus called Cryptococcus neoformans. Causes chronic meningitis. Okay. Another condition, toxoplasma, that is treatable. It's a drug that was produced by a company that was bought by a Wall Street gentleman named Martin Shkreli, who elevated the price of a drug by like 700 or 7,000%, some ridiculous, and everybody was up in arms saying that he's an asshole. And by his behavior completely supported the claim that he's an asshole, but he legally was absolutely fine because he bought a patent to that drug. But as you know, you don't mess with government. So government got really unhappy, started to dig in his Wall Street past, found a lot of violations of Securities and Exchange Trade laws, and last year he was finally put in jail for 7 years. He didn't believe it's going to happen, but everybody was so excited that he went to jail. It was awesome. So toxoplasma is pretty common in AIDS patients. Cardiovascular, lymphatic, not something very specific, basically an infection. I would highlight Mycobacterium tuberculosis, both respiratory and systemic infections characteristic. Respiratory, tuberculosis, any mycobacteria actually, and candidiasis. Okay. One that is not on the list is called, I'm going to give you an acronym, you will see it in the clinical practice, called PCP, Pneumocystis carinii pneumonia. It's hallmark infection. GI tract, Cryptosporidium parvum, terrible disease. It's caused by protozoan, Cryptosporidium parvum, chronic diarrhea. Cannot be cured. In AIDS patients, cannot be cured. HPV on the genitals, also very common HPV-caused cancer is anal cancer in patients with AIDS. Now, I believe I pictured a pretty terrible picture of consequences. Now, we now have a very good antiretroviral therapy. It's called HAART, which stands for Highly Active Antiretroviral Therapy. And we have drugs that inhibit fusion, entry, reverse transcriptase, integrase, and protease. HIV is considered to be a chronic disease, like diabetes or hypertension. Life expectancy of a patient with HIV who is on the antiretroviral therapy is the same as of the patient without the infection. I'm telling you, Magic Johnson is going to play my funerals. You know, he's going to live longer than anybody. Now, in the U.S., basically, it's the chronic infection that is very manageable and so on and so forth. Problem is that treatment is expensive. This table shows you different combination treatments. And now, why combination treatments? Why we don't use the single treatment, single drug? Always treat HIV with 2 or 3 drugs together. Any idea? Resistance, yeah. Virus can develop resistance really quick. When there are 3 drugs together, no chance. And physicians will still change the combination every so often, every several years. They will still change the combination of drugs. But we have so many of them, really, that it's not really a problem to go like new combination over and over. So you can see that we're talking about $7,000 to $8,000 per year. Just the drugs. Plus tests. And all of it accounts for $13,000 to $18,000 a year, which you can calculate, a bit more than $1,000 a month. It's a lot of money. Now, as far as I know, insurance covers it here, but it doesn't cover it in Africa. So companies actually are willing to reduce the cost, but they cannot sell it for free. Well, it's not selling, they give it away. So non-profits is the answer. Okay. Vaccine is not available. Okay. For many reasons. First, we really don't have any good vaccine. Just nothing worked. When HIV was discovered in 1980, people said, we're going to have a vaccine in 2 years. Yeah, right. It's been 39 since then. Still don't have a vaccine. Virus mutates really quickly. But the biggest challenge probably for the HIV vaccine, if you give it before, like if you vaccinate population just like we vaccinate against measles or something, it has to be 100% effective, not 99.9. There should be no infection. You see what I'm saying? Because if a person is infected, that's for life. So now vaccine attempts, these are vaccine design attempts, they shifted towards vaccines that would lower the virus. Like instead of the drug, basically, you give a person a vaccine which somehow stimulates immune system to reduce the virus load after the infection happened. Now, preventative strategies. So condoms. Condoms are 99% effective if we account 1% for any, slipped or broken or something like that. They will be 100% effective if you put one, then the layer of super glue, then another, then the layer of super glue, then the third, and never have sex. That's 100% effective. Now, Truvada, the preventative drug. Basically, it's the antiretroviral drug. It's the reverse transcriptase inhibitor that people who are in the high-risk population take, and that significantly reduces their risk to get infected. Doesn't make it zero, but reduces, okay? But, in all honesty, condom sounds like cheaper and more reliable option, really, And yeah, somebody who tells you, no, that's not true, virus can get through the pores in the rubber that the condom is made of, well, if any virus can do that, that's the champion. No, they can't do that. No, there's no way. Virus cannot penetrate. No. So I will see you on